Fine, Nadia. And how are you too, please?
Thank you, madam.
Okay. Yeah. Please, my name is HAJIA Halima Opuku AHMED. You can call me HAJIA, and I'll be taking you through the normal labor. I think I've already started with APRS with you, Anatomy and Physiology of the Reproductive System. And so, because this is a new one that I'm going to start with, that's why I'm introducing myself to you. Please, the do's and the don'ts of this lectures is that we don't expect people to be making noise whilst lectures is in progress. If you know you have something doing, please, then you leave the page and go and do it, and you come back. Other than that, when you start distracting the class, then AHMED will put you in the waiting room. You remain there to finish the lectures. So try to make sure that you comport yourself. If I say something you don't understand, please ask for clarity. I will explain it to you. But then if you don't pay attention, and then we say something and you want us to go back again, that one is like we'll be delaying the group. That notwithstanding, you can still ask for clarification. Thank you very much. We are going to talk about normal labor, which you did during your diploma level. So please, and in my class too, when you contribute, when individuals contribute, I have some, at least you have some marks. It offers you at least some marks. So class contribution is also welcomed. Now, let's define normal labor. We are starting. What is normal labor? Whatever you know, you just say it. I'll polish it up for you. If you say it is right, we continue. What is normal labor? And
normal labor
since I have your name, mention your name. Mention your name.
Please, my name is Boabin Janet.
Janet Boabin, okay. Go ahead.
Please, normal labor is a regular painful uterine contraction, accompanied by cervical dilatation and facements. With the complete expulsion of product of contact up to 6 hours later.
Thank you very much. Thank you. In the first place, what is labor? We've been saying labor. What is labor? I have your names here. And so if I realize that people are not raising their hands, then I can call you. And when I mention your name to contribute, don't dodge, don't leave the page. Say what you know. After nobody is going to beat you or shout at you or insult you. No. So your participation matters. Elizabeth, what is labor?
Yes, madam. Please, is the rhythmic uterine contraction from the onset of labor to the expulsion of the baby.
Okay, that is labor. Okay, any other definition for labor? Thank you very much. Any other definition for labor?
Hello, madam.
Your name.
Irene Asari Krama.
Go ahead.
Irene. Yes, please.
Yeah.
Please, labor is the process by which the uterus empties its content after the 28 weeks of pregnancy. Thank you.
Thank you very much, Irene. Thank you for that definition. Okay, now let me quickly take the labor. When we say labor, is the process whereby, and I hope you have your pens and your jotters and your notebooks with you. People, it has even reminded me of something. Because you are midwives already, the moment you hear that we are talking about labor, your interest is low, your participation is low. But when we start, you get to know, as we go through, you get to know that even though you know labor, but then because of the degree in midwifery, there are additional points. It's the same labor though, but you see that there are additional information that you'll be getting to what you know. So don't undermine labor. People do that, and at the end of the day, they are fed in labor and they don't understand. Overcomplacency. Do away with overcomplacency, please, and allow yourself to be taught. Okay, so labor is the process whereby the product of conception Labor is a process whereby the product of conception, that is fetus, membranes, placenta, amniotic fluid, or glycoamine are expelled through the birth canal. You see, that is labor. It's a process whereby the product of conception, that is the fetus, placenta, membranes, cord, amniotic fluid, or glycoamine, are expelled through the birth canal. After the 24th week of gestation. After the 24th week of gestation. So that is labor. Now let's see the normal labor. Because we have preterm labor, we have precipitate labor, we have so many types of labor, but we are talking about normal labor. What is normal labor? Sorry. Elizabeth, what is normal labor? Anybody? What is normal labor? Yes, Kafui, Ruby. Ruby, what is normal labor? Okay. Normal labor. It starts from when the pregnancy is at term. Normal labor starts from the process where the pregnancy is at term. Baby presents by the vertex. The baby is born or it presents by the vertex through the normal birth canal,
Sister,
within a period of 15 to 18 hours.
Sister.
Yes, madam.
Sister, please, I think Janet Boabing hasn't unmute herself, so her background is disturbing us.
Janet Boabing, please mute yourself before I put you in the waiting room. Janet Boabing, can you mute yourself? Okay, thank you very much. So normal labor is the process whereby the pregnancy is at term. The fetus the fetus presents by the vertex. It is born within a period of 15 to 18 hours. The baby passes through the normal birth canal. Without any complication to the mother or baby. Without any complication to the mother or baby. That is where we can say the woman had normal labor. Because people deliver, and sometimes they are delivered through the abdomen. That is through cesarean section. Though she has delivered, it's not normal. People deliver, but the baby presents by the buttocks or the podalic. It is not normal, though she has delivered. So any presentation that is different from that of the vertex of the fetal head, we term that one as abnormal. But then if the baby presents with the vertex, and you know the vertex is the dome-shaped area on the fetal skull. That takes the circumference of the bregma, the occipital protuberance, and the two parietal eminences. So that shape is what we mean by the vertex.
Hello,
that is it.
Ajia, please can you take that for me again?
I said, which one, please? The definition or which one?
Please, the vertex.
Oh, the vertex.
Please,
I'm only trying to give you a picture of the vertex. And I said it is the dome, a dome-shaped area on the fetal scar. It takes the circumference of the bregma. The bregma is the same as the anterior fontanelle. In fact, some books say it starts from the two frontal bosses. That is the frontal bones around the bosses, frontal bosses. Well, another book is also talking about the bregma, right? So let's take it from the frontal bosses. It's going round, then it will pass through the parietal eminences. Parietal eminences is going round. Then it goes back. Then it goes back to. I've put her in the waiting room. She should go and take her 10 CDs from the waiting room there. Let's continue. We are starting new topic. I've told you, keep quiet. You don't want to. I've put her in the waiting room. Should I bring her back? Let her remain there small because she started making noise.
Yes, please. Yeah. Mercy on her.
Yes, please, Ajia, please. Please.
And tell her to make an attempt.
For her to be aware.
Okay, so then tell her to make an attempt to enter, then I'll admit her. Other than that, there's no way I can bring her back now. Tell her, those of you who know her, tell her to make an attempt to enter, then I admit or come and I will hit on the admittance. Let's continue. So I'm tracing the vertex.
Okay, thank you.
And I go to the occipital protuberance, and then it follows the same direction at the opposite side and comes back to the frontal bosses. That is the vertex. So that is it. Now, that is the normal labor, the definition for normal labor. Amprechum, beautiful name. I hope it's Amprechum. It didn't appear well, but Amprechum, what have you written so far? Amprechum, what have you written as the definition for the normal labor?
Ajia.
Yes, madam.
Please, I've written I said is the process whereby the pregnancy at term, the baby is born or present with the fetus through the normal birth canal through the period of 15 to 18 hours without any complication to the mother or baby.
Great. Thank you very much. I think that is all that I say. Okay. Now let's continue. Let's move on.
Edja, please, the definition of labor. I didn't get the gestational age. Is it 24 or 28, please? My network was poor.
The definition of labor. Please, those of you who heard me, can somebody repeat it for her? Just the
yes,
labor,
please.
He said
yes, the labor, the definition was
Labor
the process whereby the products of conception are expelled.
That is the fetus, membranes, placenta, amniotic fluid are expelled through the birth canal after the 24th week of gestation.
Yes.
Gestation.
That is what I said. That is labor. And I said that we are using the yardstick to be 24 after the 24th week because we have preterm labor. And that one will be after the 37th completed week of gestation. we still call it labor, but it is preterm. And before the 24th week, it is abortion. You can't tell it, you can't say it is labor. Before the 24th week, when the pregnancy comes out, it is abortion. After the 24th week, you can get labor, but that will be preterm labor. And that will be after the 37th completed week of gestation. But then when we are talking about normal labor, we said the pregnancy should be at term. I hope you get the difference.
Okay. Yes.
Is it okay?
Yes. It's really clear now. Yes.
Yes, sister.
Thank you very much. Thank you very much. So let's continue.
Thank you.
Now, let's see the premonitory signs of labor. There are other signs that precedes the actual labor. But before then, let's talk about the stages of labor. Let's talk about the stages of labor. How many stages of labor do we have?
Please, 4 stages. Please, we have 4 stages.
4 stages.
4 stages. Yeah, 4 stages. 4 stages.
4 stages. Good.
4 stages.
Good.
There are 4 stages.
There are 4 stages
So
of
the
labor.
first stage.
4 stages.
The first
It's okay.
the first stage, second stage, first stage, and then the fourth stage. So we have first, second, third, and then fourth stages of labor. Now let's see. Okay. So, with regards to the first stage of labor, please somebody should define first stage of labor.
First stage of labor is the stage where
No, mention your name, please.
is the onset of labor.
Hello. Please wait. If you want to answer a question, just raise your hand. You raise your hand, then I'll call you. So that if I see many hands, I'm likely to call only one person. Because other than that, if everybody decides to talk, who will listen to the other? If everybody talks, who will listen to the other? So please, let's try to. So let's see. Now I can see Zanori, something. Yes, tell us. What is first stage of labor?
Okay, Haja, please. The definition for first stage of labor, it commences.
Raise your voice a little bit. Raise your voice.
Okay.
Raise your voice.
It commences with the rhythmic regular uterine contraction.
Please, I'm taking a foreign call, so you continue.
Okay, it commences with a rhythmic regular uterine contraction until full dilatation of the cervix. Okay, so I'm saying with the first stage of labor, it commences with rhythmic regular uterine contraction until full dilatation of the cervix. Yes.
Okay, so please go ahead.
Okay, HAJIA. Please, I said it commences with a rhythmic, regular uterine contraction until full dilatation of the cervix.
Good. So that is the definition for the first stage of labor. The onset, it is the onset of regular, painful, rhythmic uterine contractions taken up of the cervix till full dilatation of the cervical os. I'm taking it again. I'm saying that the definition for first stage of labor, it is the onset of regular, painful, rhythmic uterine contraction taken up of the cervix till fully dilatation of the cervical os. Then we say the woman is in the first stage of labor. I hope it's clear. Because we have what you call forced labor. Forced labor. But we'll try to differentiate between true labor and then forced labor. So I hope it is clear now.
Yes.
Okay. Now, let's define second stage of labor. But we said there are 4 stages of labor. So let's define second stage of labor. Anybody? Empress Tina, define second stage of labor.
Please, the second stage of labor is the stage of expulsion of.
Oh, your line is breaking, madam. Your line is breaking. Can you take it again?
Of the fetus begins with full dilatation. Please, I said it is the stage of.
Oh, is it breaking from my end here or? Your line is breaking, so can somebody else take it up for her? Or is it my place? Is it only my place that the network is not good?
Hello, sister.
Yes, yes.
Please, the second stage of labor, it starts from the full dilatation of the cervix, which is 10 cm, to the expulsion of the fetus.
Okay. Thank you very much. That is the second stage of labor. Thank you for that definition. It starts from 10 centimeters cervical dilatation and then complete. The word there is complete expulsion. Complete expulsion of the fetus. So that when the fetus is completely delivered from the birth canal, then we say second stage of labor has ended. Thank you very much. Now let's see the third stage of labor. What is third stage of labor?
Sister.
Yes. Who? Ibrahim.
Please, I'm
Ibrahim. You are who? I have seen 3 hands. That's why I'm calling Ibrahim.
Please,
I've seen your hand.
The third stage of labor is the delivering of the placenta and its membranes.
Okay, the delivery of the placenta and membranes. Any other definition?
Hello.
Yes.
Madam, can I talk?
Hello, sister.
Your name? Yes.
No, Rabiat.
Okay. Rabiat, go ahead.
Third stage of labor is the stage where the placenta is delivered and placenta and membranes are all delivered until uterine is contracted with the control of bleeding.
Thank you. So that is the definition. The expulsion of the placenta and membranes complete expulsion of the placenta and membranes, and control of hemorrhage. If I ask you to define third stage of labor, you don't add that aspect, then you haven't defined third stage of labor. You should be able to control bleeding, and that will give you the confidence to say that. I have to give you the confidence to say that I have managed third stage of labor. Thank you very much. Then what is fourth stage of labor? Please, what is fourth stage of labor?
HAJIA.
Yes, madam.
Please, the fourth stage of labor, it is a continuous vigilant observation of both the mother and the baby during the first 6 hours after the delivery of the placenta and the membrane.
Okay. Good. Thank you very much. That is the fourth stage of labor. It's a period of vigilance. The 6 hours vigilance. The 6 hours of vigilance observation of the mother and baby. That is after delivery. The first 6 hours that the midwife will have to monitor the mother and the baby vigilantly to ensure that mother is not going through any complication. Baby is not bleeding. There's no cord bleeding. Mother is also not bleeding. Her vital signs and other things are all well with her. Then you can say that you have managed fourth stage of labor very well. Okay. So that is the fourth stage of labor. So these are the various stages of labor. Now, before we continue with what we need to do, what we need to know during first stage, what we are supposed to do, and all that, there's something we call clinical decision making. For example, a client has come to labor. You are the one on duty. Sometimes you are the midwife in charge of Suku Clinic, or you are at Yamecha, very far away. Now, what do you do? So there's something we call the strategies in clinical decision making. You have to take a decision as soon as the woman comes to you or comes to your facility. So we are saying that the clinical decision making, in fact, is a way of judgment. It's a way of judgment. You are judging deliberately or intentionally. You are judging to solve a problem. When the woman comes, once you are the one on duty, once you are in charge of the place, there's a need for you to take a clinical decision by deliberately finding a way of solving problems so that you arrive at a conclusion whereby you develop basis or on actual basis that is perceived patient needs and response. For example, typical example of this perceived needs is that when the client comes, you have examined the patient, but then she tells you, Madam, as for me, anytime I come to deliver, either they use your machine to extract my baby, or they will send me to operation room for operation. You see, at that level, you, the midwife, will have to take a decision. That is what we mean by clinical decision making. Take a decision because you are alone at that facility, or you are aware that the anesthetist or the medical officer, they have traveled. You take a clinical decision. Because of that, the woman has given you a clue regarding her process, her labor process. So you take a decision, and then you refer the client to a facility where she can be properly managed. Hey, who is that? Who is making that noise? Please, all those who stand for.
It's Rufia to please mute yourself.
Thank you. And those of you whose hands are up, I haven't asked a question yet. Can you put your hands down? Then we continue. Okay. Okay. So that is it. Then you plan. In clinical decision making, you take a plan. So you plan based on the identified knowledge. Previous clinical encounter, like I said, the woman is giving you a history that anytime she comes to deliver, they have to use instrument to extract the baby. It's an information that she knows herself, and she's telling you, you don't ignore. You don't ignore. So when we talk about problem-solving activity, we are talking about a deliberate problem-solving activity or a process whereby a proper organization is made. You organize a way of giving care to the pregnant woman. The problem-solving method is also referred to as the midwifery management process. Midwifery management process. Or it can also be called the client management process. Because these processes will help you, the midwife, to learn the steps that you need to find out what is wrong with the woman. And then you decide on how best you can plan to help the woman. So let's see the steps that are involved in the problem-solving process. We are talking about problem solving. The fact that she has come in labor pains, there's a problem. We are coming to solve it. What kind of problem is it? She's in labor. It's a problem. How do you solve it? How do you plan it? Based on what you are hearing from the clients, based on what you are observing on the clients, and then based on what you have seen from the patient's previous knowledge. So there are 4 main steps that every midwife will have to follow to make sure that she's doing the right thing. 4 major steps that every midwife, when you're in the delivery room and a client comes, you have to follow these 4 steps. What are they? What are these 4 steps that we are talking about? Yes, anybody? Oh, Abuaji. Is it Abuajiwa or Abuaji? Oh, somebody's on this. Okay, Maria. Maria.
Emma, please, proper history taking.
Proper history taking, good. Any other, there are 4 steps.
Please, also
critical observation of the client.
Critical observation of the client, because sometimes you think you are going to manage the woman during the first stage of labor. Meanwhile, she's in the second stage of labor. So that if you are not looking at the patient, if you are not feeling what she's feeling, then you are likely to miss one of the problem-solving steps. So let's quickly see the 4 steps. The first step is ask and listen. Ask and listen. Now, let me ask this question. It's a general question I'm posing to you. And be sincere to yourself. Come out with the truth. That is where we can say that academic honesty. We are talking about steps that are involved in problem-solving process. And we are saying that there are 4 steps. We said the first one is ask and listen. Do we normally ask and listen? Be sincere to yourself. Yes. The one whose hand is up. Go ahead. Have you made it a routine that we ask clients questions and then we listen? The question we can ask, but even the listening aspect is what I'm interested in. Do we listen to our clients? Oh, please, what you have been doing in the ward, share with us. Yes, Belinda. Belinda.
Yes, HAJIA. Please, good morning. Please,
good morning.
What I personally have been doing is anytime there's a labor case, I welcome the client. The first question I ask is the onset of labor. When did they start? Are your pains very intensive, or do you feel the urge to push the baby? Ask these questions and I listen to what the client will say before I even assess the client to ascertain whether I'm dealing with the second stage issue or the first stage issue so that I know how I organize myself.
Thank you very much. Thank you very much. Stella Zim, what is the Zim for? Stella, okay.
Madam.
Yes.
Yeah, please. May I mostly ask an open question, which is, how may I help you? I'll first of all welcome you. Then I'll give the person a seat. Then I'll now give an open question, how may I help you? So the person would definitely pour out their problem. So I'll now look at whether they are actually the fifth sign of labor.
Okay. Thank you very much. I think we are all saying the same thing, and that will come under the management of first stage of labor, which will take it as this. So, ask and listen. This is the first step that must be taken. Yes.
HAJIA.
I'm taking it. Yes, sister. Yes, go ahead. I'm listening to you.
Please, Mohammed, HAJIA Matiti talking.
When a woman comes,
so
consider the parity before.
Oh.
Okay. Okay. So let's listen to what we also have. Ask and listen. We are saying it is the first step that is involved in the problem solving process. This is the first step that must be taken when seeing a woman in labor. Ask questions about the reason that brought her to see you. Like one of you just said. Ask her, how may I help you, madam? What has brought you here? You see, you have asked her. You are listening to her. But don't forget the attitudinal aspect. And that is where my problem lies. That is where some midwives are lacking. They can ask, they can listen, all right, but the attitude, the way and manner that the question is asked, the way and manner that you will listen to the client is enough to close the woman's service for her. It is enough to contribute to prolonged labor. I'm interested in the attitudinal aspects. You can act all right. You are listening all right. But the attitude, because if you ask her, when did labor pain start? When did it become so intensive that you decided to come to the facility? You have asked her all right. But then if you ask her in a different way, I'm talking about attitudinal way of asking things. Hey, my mom said, they will say I work out. You say you are in labor. Yeah. The way you are standing there, what shows that you are in labor? My friend, sit somewhere, let me. Have you seen show? Have you seen any water coming? Oh yeah, give me chance and let me rest you. You are not in labor. Look at your face. Obi a work out our say. You see, that kind of attitude is enough to scare the patient. It's enough to put the patient off from that facility. So we are saying that ask and then listen. And we are saying that it is the first thing that you have to ask or find out from the woman on seeing her the first time. Ask questions about the reason what has brought her here to see you. Then you listen carefully for answers. The word is listen carefully. Some of us are not good listeners. We are not good listeners at all. The patient is telling us something. At the same time, we are on our phone. We are conversing with somebody on the phone. And you are, at the same time, you are asking a patient some questions for clarity or for answers. Patient may say a word or a sentence that is so important. So important, but because at that same time, you have divided attention. You have divided attention, so you didn't hear. She said, you asked her, have you delivered before? She said, yes. But then she added that, but me want to me. Very short sentence. But because you were engaged in other conversation, you didn't hear to me. You didn't hear that she's giving you an information that she has a history of PPH. You didn't hear that one. Why? Because you are not a good listener. Why? Because you were having divided attention on a phone, and then at the same time, you want to listen to the patient. And the possibility of ignoring what the patient is saying is higher than you listening to the conversation on the phone. So we are saying that ask questions for clarity or for answers. But then I'm saying that you should have a good manner. Your attitude towards the patient must change so that you can get the information that is needed from the patient. Because all answers, any answer that the patient will give you will help you to find out the problem. She has a problem of prolonged labor. Mamiwa will say, how many times have you given birth to? He said 3. But then she added, but I am a check. You were not paying attention, so yeah, I'm a check, meaning that I keep longing during labor. You didn't hear that aspect. And so how are you going to solve the problem? So that this time round, you are trying to prevent prolonged labor and its associated complications. Please, do you have any question on ask and listen as the first step that the woman tells you and you go by it? Any question? Can I continue? Can I continue?
Yes,
the second
please.
step is look. Thank you very much. The second step is look and feel. Look and feel. This is the second step of the problem solving steps. So you examine the area of the woman's body based on the information in the step 1. Examine the area of the woman's body. That is, examine the woman's body, right? Based on the information that she gave you during the ask and ask. So based on ask and listen,
Sister Debbie, please mute yourself. Jesus.
So once she has involved the husband, let me find, what is her name? What's her name?
Deborah.
Let me find a way of putting her in the waiting room.
We don't have to consider. Always.
Oh, I won't consider. So that is it. So we are saying that you examine the woman's body based on the information that she has given you in the step 1. For example, if a woman complains of vaginal discharge, you want to do a speculum examination and probably pelvic examination based on what she has told you. You know, during pregnancy, they have this leukorrhea, excessive vaginal discharge. It's normal. But to her, because she wasn't educated on it during pregnancy, She thinks it's abnormal. And that is why she will tell you that, Madam, I'm having excessive vaginal discharge. But during pregnancy as a midwife, the first thing that should come into mind is leukorrhea. So what will let you know that it's ordinary leukorrhea, but it's not infection, is that you ask her, is it offensive? Do you have vulvar itchiness? I'm citing an examples for you so that you can remember when it comes to decision making. You ask her, the discharge that is coming, is it offensive? Do you smell something? If your vulva itching you, then she'll say, no, I'm not experiencing any of this thing. It's not offensive. But it's leukorrhea and she's disturbed. So that you can take a decision. You can take a decision by, let's say, doing vulva swabbing or high vaginal swabbing to isolate any organism, based on which treatment can be given. I hope it's clear now. So it will all help you to identify even problems that the woman herself doesn't know. She herself might not even know that probably she's even a diabetic. She's complaining to you, she's having pruritus vulvae. Pruritus vulvae is itchiness of the vulva. That is what she is telling you. But on your inspection, so you decide. Let's move on. Alimatu, I've put you in the waiting room. When I admit you and you come back, behave well. Please don't do that. You are mature students, and don't do that. You have paid your school fees, and you should benefit from it, please. Okay. So somebody's hand is up. Do you want to ask a question? If it's an old hand that is raised, please put it down. That is if you don't have any question to ask. Okay, so let's continue. So that is, we are trying to identify the problem needs. We are saying by asking, by looking and feeling, you'll be able to identify a problem. Sometimes patient comes and you see that just at the look of her face, you can easily see that she's having puffiness of the face. Her face is puffy. She's having pedal edema. You are suspecting preeclampsia. But she herself doesn't know that she's not well. She doesn't know. But as soon as you see puffiness of the face as you look, then you listen to, or as you feel by touching or pressing on the ankle. That is the inner, most of the time, the inner aspect of the malleolus bone of the leg, of the feet rather. You press on the malleolus and you see that it is dimpled, it is indented. Then it tells you that she's likely to be anemic or she's having signs of preeclampsia. And that will help you to take immediate care or an action to address the situation before even labor sets in. Please, do we understand what I'm saying? Are we together? Are we on the same platform?
Yes.
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 Very
Yes.
good.
Yes, ma.
Good.
Yes, Ajia.
So now let's see. We are saying that identify the problem needs. Identify the problem needs. The midwife must identify what the problems are using the information from the first two steps. The first two steps are look and then feel. The first one, we are talking about seeing, asking, and then listening to the client. Then you look and then you feel what is happening. So now you identify the problem needs. So we are saying the midwife must identify what the problems are using the information from the first two steps. So it's important that all problems are seen, or all problems that are seen are considered to be something worrisome, not just what the woman reported to you. But if you're a good observant, you can observe other things from the woman. You realize that she's having jaundice, severely jaundiced. For all you know, she hasn't even seen that. One of the last time she even looked at her face in the mirror. So she hasn't seen that she's jaundiced. But you, because you looked, you saw that she's looking jaundiced. She herself might not even know that she's anemic. But because you looked, because you checked the conjunctiva, you saw that she's looking pale. Then quickly you can address it before it becomes an issue, before it turns into postpartum hemorrhage because of the anemia. After delivery, she bleeds just a little bit, and it's enough to send her into shock. So that's why we say, listen, look, feel, ask, and then we take a decision. So now we take proper or appropriate action. Take appropriate action. That is taking action is the fourth step in the problem-solving processes. Then the midwife will now decide what should be done to take care of each problem that or the needs that the patient is having. The problem that the patient is having, we are now going to take appropriate action. So the following areas should be considered for each problem or each needs. Consider medical treatment. Take care of the problem with medicines or treatment indicated. Then remember, all medicines must be used with caution during pregnancy. That is one thing that you should know. Sometimes the woman can even tell that, Madam, I passed worm. You want to start the mebendazole. You want to deworm her. How old is the pregnancy? Because it is not at any age of pregnancy that mebendazole should be given. Though you have listened to her, you want to take a decision. There are other things, other investigations that you have to do. If the patient tells you, Madam, I went to the loo, I went to the washroom, I went to the toilet, and then I could see a worm in my toilet. You have to give her the worm, but then find out from the woman her gestational age. How old is the pregnancy that you are going to introduce a dewormer? Because at certain age of gestation, the drugs are toxic to the fetus. There's something that we call teratogenic effects. Teratogenic effects. And that depends on the type of medication that you give. So we are talking about medical treatment, and we say, take care of the problems with medicine or treatments indicated. And we are saying that, take note that all medicines must be used with greater caution during pregnancy. Now, education. Education. You teach the woman information needed to care for herself. Teach her. Counsel the woman. Let her understand the information that is needed to take care of herself. For example, I'm giving you an example. For example, the first one, she complained of excessive vaginal discharge. As a midwife, what advice will you give her? We said, what education will you give her? Talking about vulvar itchiness. or excessive vaginal itchiness? What do you tell her? Yes.
Personal hygiene.
Personal hygiene
I will
by
tell her personal
doing what?
hygiene.
Personal hygiene by doing what?
But
Personal
by
hygiene
educating
entails
her
a
how
lot.
to keep the place neat. Uh-huh.
By educating
One
her,
is shaving the perineal part,
you should
educating
shave
her about
the
shaving the perineal area and then
uh-huh.
perineal area. Uh-huh.
And when she
And then
goes to toilet, she goes
when
to
she
toilet,
urinates, she should use a tissue to
clean
clean
from
from
front to
front
back.
to the back.
Okay.
Wash the trolley with
And
clean
then
water.
wash the panties and dry them in the sun.
Okay.
If possible,
You
you
wear
iron
cotton
the
panties.
panties.
If you wear cotton panties, okay. So these are the education that you give to the clients.
She should also
Please,
avoid
when you
nylon panties and then nylon underwear.
okay,
And
okay,
please, you should also stop bleaching. Bleaching.
good. You should stop bleaching. I like that. You should stop washing the vagina. You know, because of the itchiness, they end up to wash there. It should rather be the vulva and not vagina. Please, anybody who comes across vagina washing in any book, please, I'll give you my number. Call me. I've read a lot of books. What you come across is a vulva washing. But midwives, we ourselves, we are guilty of it, washing our vagina, struggling with our vagina. Some people bath and they leave at least 3/4 full of water in the bucket. What is it coming to do? She's coming to wash the vagina. She's coming to struggle with the vagina proper. Please leave the vagina alone. Wash the vulva. Because if we ourselves, we are guilty of it, we cannot tell the patient to do same. We cannot educate our client to do same. So let's practice the right thing and then we can defer it onto our client. So that is what you are supposed to do by taking appropriate action. We have cited examples and we have spoken about dedication. Then counseling the woman. You counsel her, the counseling will help the woman to understand the problem and help her herself to develop ways of dealing with the issue. So that when you take her through the counseling, that madam, you say we are using that as an example. You say you're having excessive vaginal discharge. Please, during pregnancy, it is normal. And we call it leukorrhea. It is normal, it is bound to happen. But what you can do is you can wear a linear pad so that when it gets soaked, you can change it at frequent intervals as if you were in your menses. Now, when you go to bath, you can also tell her that as for the vulva, you can even use soap and sponge and then wash the vulva, bath the vulva. But the vagina, don't introduce your hand there. Who knows? Maybe through the introduction of the hand that we are getting this itchiness.
Hello, Ajia. Hello.
Stop it. When you stop it,
HAJIA, please, we can't hear you.
Oh, thank you very much. For how long have you not been hearing me?
Yes. Oh,
For a very long time.
for the past week.
For the
3 to
past
5 minutes now.
Oh,
Just after
when you're not
the
hearing me.
education side, you went off.
Oh, and you didn't draw my attention.
Immediately
I've
after
been
talking
talking.
about Duchin, you weren't hearing
Oh,
me again.
We thought it was network problem.
oh no. Sometimes when you prompt me, I can change my position and then get the network.
Okay.
Okay,
Thank
I
you.
was trying to. Thank you very much. I was trying to say that by taking appropriate action, being the fourth stage of the problem solving process, that was where you said I got. Oh. Then I talked about medical treatment.
Hello, sis.
Hello.
Yes, sis. Please, I'm Victoria Usua. Please, you were saying something for the personal hygiene. You said something. You said we should educate them to wear perineal pads to prevent wetting their panties. Back in school, in my case study, I educated my clients on that. And during a Viva, my supervisor questioned me, why did I tell the client to wear perineal pads? And I explained, but later she was like, no, let me say, panty liner has been banned for pregnant women to wear it because it provides heat. So you saying that, I just want a clarification. Thank you.
Me, I'm treating leukorrhea. I don't know in what context did you say what before the supervisor said so, right?
Yeah.
I'm talking about leukorrhea. When, for example, a patient is having leukorrhea, which is normal with pregnancy.
Yes, sister. So that was what
and I said
told
that.
my client.
I said that with that, that was where I said, tell the clients that if she thinks it is excessive, she should put on perineal pad. Me, I didn't say any panty liner because the panty liner that you are talking about, the woman is staying at this place, Chebidi. That is where she is. Do they say panty liner there? No. But the perineal pad, because there's a clinic there, she may get the perineal pad. So we are saying that let her wear perineal pad because sometimes the leukorrhea is very disturbing. Tell her, madam, put on the perineal pad if you think the discharge is excessive. So that when it gets soaked, you change it. Wash the vulva with plain water. And I stress on the fact that she shouldn't wash the vagina. She should wash the vulva. Because introducing her hand inside the vagina in an attempt to wash can also cause the infection to increase. It will increase the vulvar itchiness. So I'm stressing on this because you may meet it in one of your objectives, and students don't know what to choose.
Okay, sister.
But when she's bathing, she can even bath the vulva. I stress on that. Bath the vulva. She shouldn't be she shouldn't make an attempt to wash the vagina. And I cited example that we midwives ourselves, we are also guilty of it. We are guilty of washing our vagina. We bath and then leave half bucket full of water, or sometimes quarter full of water in the bucket. What is it coming to do? She's coming to squat and then let the vagina suffer. Make sure that she will finish that water. Please, you leave it. Wash the vulva. Especially, I'll come to that when you go into details of labor. I'll come to that. Especially when you are treating infertility. When you're struggling to achieve pregnancy. And every day you will be washing your vagina. you are damaging the vaginal wall. You are preventing the passage of the sperm into the vagina and through to the cervix, to the uterus, to the fallopian tube. You are the cause. Leave your vagina alone. Watch the vulva and see if you wouldn't achieve that pregnancy. This is just by the way. I'll take you through proper. So I'm saying that. Is that okay? Can I continue? The one who asked the question. I think
You can
I've answered
continue.
you.
Yes, it's
Okay.
okay. We can continue. Thank
Yes,
you.
Sophia, please. The counseling and education, is it under taking appropriate action or is another step 5? Like I'm confused.
No. I said the 4th step. There are 4 steps. So take appropriate action is the 4th step. And it is under that we are talking about education and counseling. Hello? Are you still confused?
No, I'm okay now. Thank you, Mama.
If you are not seeing our faces, so if you don't respond, I wouldn't know that you do understand or you don't. Okay? Okay. So we are saying that then you have to take laboratory investigation that will give you more information. Then where there's the need, you refer the client to the appropriate facility. If you think you are taking a decision of keeping the patient there, but then what you are seeing tells you that the patient should go to further treatment from a higher facility. Then don't forget that you need to follow up. You ask questions to return, depending on how severe her problem is. So you find out from her whether she does understand what you have asked her. Okay. Then record. You have to record whatever information or conversation that you have had with the client must be put into record. You have to record them. It will serve as a legal backing for you. It will serve as a point of reference. So recordings are very, very key when it comes to midwifery. Okay. Okay. Then you have to review your decision and its consequences. So after you have seen the patient, you have decided the patient has gone home. Remember to let her come back for a review as to whether when she went home, she was still having the problem. How long did it take for it to stop the discharge that we use as an example? You see, so that if the decision has not been met, then the identified needs must be revisited. For example, you ask the patient to be wearing perineal pad because of excessive vaginal discharge. Let her come for review. She comes back. If the condition still persists, that is where you have to take higher vaginal swab. Maybe it is not leukorrhea as you are thinking. For all you know, it is syphilis. For all you know, it is gonococcal infection. For all you know, it's a severe form of candidiasis. So we are saying that review your decision and its consequences. Okay. 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 So now let's see we have already spoken about it, but then let's see the normal labor onset, and then we can move on to theories of onset of labor. Theories of onset of labor. What are the theories of onset of labor? Yes. Okay. Let's take the normal labor again. We say normal labor is the process that has the following characteristics as stated by who? As stated by who? That is World Health Organization have their own way of doing it, and so we said the pregnancy should be at 10. Between the 37 weeks and 42 weeks, or 280 days. 280 days, plus or minus 10 days. Hello?
HAJIA, please, we
Hello?
can't hear you.
Hi.
Hi.
You can't hear
Hi. You
me.
went off
Hi.
Please, those of you who are feeling
Please, the
sick,
network
today
is breaking.
now it's no more breaking. Is it still breaking?
No,
I know
please.
some of you have.
No. No more
Your
break.
voice is
No,
low.
please.
Can you hear me now?
Yes,
Yes,
please.
please.
Yes,
Yes,
please.
please.
Yes, can hear
Okay.
you.
Okay, better. So we said normal labor. We said the onset is spontaneous. WHO is saying that the fetus should be one. If you give birth to twins, multiple pregnancy is not normal labor. It falls under abnormal labor. So we are saying that the fetus, there should be a single-ton fetus. And then the fetus should be matured enough. Okay? The lie of the baby should be longitudinal. For example, if the lie is transverse, then definitely it will end up with cesarean section. Oh, I should go over again. Okay. We are talking about normal labor. We have defined it. I gave you a summary of it in the morning, and I'm repeating it, and I'm adding some points to it. So I'm saying that the labor, we talk about normal labor, the onset should be spontaneous. Where spontaneous means you don't have to set up pitocin drip. You don't have to give oxytocin drip before the labor should be initiated. You don't have to stimulate the labor. That's why we say the onset is spontaneous. It comes on its own when the pregnancy has ended. The pregnancy is at term. And that's the baby should be one. The baby that we are going to conduct the delivery right now, it should be a single-ton fetus, one fetus. If there are multiple pregnancy, if there are twin gestation, we can't call it a normal labor. That is what I said. And I said the fetus should be matured. What matured means at term. If the pregnancy is at term, the fetus is matured. Okay. Then I said the lie of the baby should be longitudinal. The lie should be longitudinal. And I cited an example that if the lie is transverse, then definitely the woman cannot deliver per vaginum. Baby will have to be delivered through the abdomen, that is CS. And so we said the lie of the baby should be longitudinal lie. Then the baby should be presented by vectors, which we said at first. There should be spontaneous expulsion without any aid. Spontaneously, baby should come out through the normal birth canal without any complication to the mother or baby. And we said, we added at first that it should be within a period of 15 to 18 hours. There shouldn't be any complication to the fetus or to the mother. So that is it. Any question? Other than that, we move on to the theories of onset of labor. Let's see the theories of onset of labor. Yes, sister.
Yeah, please. I have a question pertaining to the term
Pregnancy.
gestation. Yes.
Okay.
So when it comes to the term, the range, because I don't know, 37 completed weeks, is it term? Then about 40 or 40 weeks, I don't know the range. That's my problem when it comes to the normal science. And then this in
Then
the
let me
hours too.
answer.
Can I continue? Please, the hours of the hours too is a problem because I don't know, pyramid, the length there should be extended to 24 hours. I don't know whether it's true. And will it also be termed as normal? Thank you.
We're talking about the first one. You said that the hours, oh no, the term pregnancy, that is 37 completed weeks. Is it normal?
Yes.
Yeah, that's the
It's
question.
normal. It's normal. 37 completed weeks is normal. 38 weeks, 39 weeks, 40 weeks. It's normal, it's within the normal range. But then we are talking about normal labor so that after the 40th week, it becomes a post-term. That's why you people will say post-maturity. That's what is post-term. If the baby is also born before that 37 completed weeks, it's also a pre-term. It's also a pre-term. But we are talking about term babies. So if the baby is born at 37 completed weeks, it's a term baby, though the baby may be having some characteristics of a preterm because of its nearness to below 37 weeks. But after the 37 completed weeks of gestation, when the baby is delivered, it is a normal baby. 38 weeks, it's normal baby. 39, 40 weeks. But after the 40th week, it is a post-term. And you can't say it's a normal labor. It's a post-maturity, post-term baby. Please, have I answered you?
Yes, HAJIA. Then the hours too.
Okay. The hours you are talking about after 24 weeks, 24 hours. Is that what you said?
That is for the primates. Yes.
So when it comes to primate, don't be talking about primate. Use the right terminologies. What do you mean by primate? Don't mind me. You tell me, what do you mean by primate? Maybe I should have asked you that first. What do you mean by primate?
HAJIA, I stand to be corrected, please.
No.
Hello.
Yes.
Someone who has
Primate is
never
someone who has
delivered
not given birth before.
You see that? You know what? You see the WhatsApp.
It's a primigravida.
I think had it not been the time, the duration, but I was trying to get you the terminologies. Terms used in midwifery. I'll try to get you the terms used in midwifery. You see, you're all saying that a primate is somebody who has not given birth before. And you even go to the extent of documenting this kind of way, this word there on patient's document. Please, when we say primate is a short form of primipara.
Yes.
Primate is a short form of, yes, primate is a short form of primipara. And primipara means somebody who has given birth to a child before. Primipara, primary para. But no midwives have shortened that word. The moment you say primate, you are referring to somebody who hasn't delivered before, which is wrong. And when in your mid-semester exams, I'll bring those things there. I'll bring them because primipara It's a short form of the primip that people are talking about. You have shortened the primipara to be primip, meaning that first time she's coming to deliver. No, it's wrong. Primipara is somebody who has given birth to a child before. If you want to say she hasn't delivered before for the first time she's coming, then you can say enuriparos or primigravida. A primigravida woman. She's pregnant for the first time, she's coming to deliver. But if she's a primipara, or we are so-called primip, she has given birth before. So when the primigravida delivers, that is the time you can call her a primip, because she has given birth to a child for the first time. So she's now a primiparos. Hello. Hello.
Hi.
You are not doing the children.
Hi, HAJIA.
You see how quiet you are now. You are not
Yes,
even behaving like you are
Hadia.
it's over the
It is true. This one is as if
serious.
you are removing our panties here.
Yes. But it's not you alone. It's all over the place. So when you teach students, they go to the ward and they hear it and they are confused. And they dare ask the midwife in charge that, please, you said it's a premier, but she has delivered. Hey,
Please, HAJIA, go over it again.
Take away
I beg you, go over it again.
If you wouldn't mind, please, I was thinking at your level, you might have passed through all these things. So that's why I didn't give you the terminologies. We have terms used in midwifery. Please do, course rep, do remind me so that I can screenshot it and send it to you. I think it will help you. So I'm saying that you say I should go over, I'm going over. Ideally, to be honest with you, when I saw the timetable, I thought it was another person, one lecturer who was going to teach you labor. I didn't know it was me. So I'm now through labor because I've taught labor for so many years. That's why I can deliver even without looking into anything. But then I'm saying that when we talk about primipara, it is primiparous woman. It is the primipara that you midwives have shortened the word and you have made it primate. But primipara means somebody who has given birth to a viable child for the first time. Then we say she's a primipara. But if you want to say that she has come to labor, she hasn't delivered before. She's not pregnant. She has come to labor. If you want to use the right terminology, then she's a primigravida. She's a primigravida. And after delivery, she becomes a primiparous woman. Please, what you just posed there on the question side, bring it again and let me see what you have written. You bring it up and let me see what you have in the chat box. You bring it back. I'm interested in it, but I couldn't read it to the end. Okay, bring it. You bring it. I also look at it. So I'm saying that if a woman comes to labor and she's pregnant for the first time, she's a primigravida. It is after delivery that she becomes a primiparous. And I'm saying that it is the primiparous woman that you people have shortened it to become primip. Or nuripara means someone, or you can say she's a nuriparous woman. A nurip, yes, she hasn't delivered before. But midwives have copied this word. They have acquainted themselves with this word to the extent that they can even document. They used to document it on the patient's folder. Primate in second stage of labor. She's a primate, but she came in second stage of labor. Who told you she's primate? She's a primate gravida, but she came in second stage of labor. Well, accepted. Is that okay? Can we continue? Can I continue, please?
Yes, please.
Hello.
Yes,
Thank
sister.
you.
Yes,
Yes,
sister.
please.
Yes,
Thank you
sister.
very
Yes,
much.
sister.
Thank
Okay.
you.
You're welcome, sister. So let's see the theories of onset of labor. Theories of onset of labor. In fact, the exact mechanism that initiates labor is not known. The exact mechanism that initiates labor is not known. Woman has become pregnant for 9 good months, but a day will come that this baby must come out. No matter what, it has to be delivered. So there are certain theories, there are certain factors that contribute to the initiation of the labor. That is what we mean by theories of onset of labor. So there are a combination of factors that can spark off the labor. And we have grouped them under hormonal and mechanical. Okay.
That is the last one.
Somebody is posting something from the chat box, but she doesn't wait for us to finish reading and then she will clear it. Okay. Okay, let's continue. So we are saying that there are certain factors that help the woman to initiate labor. And that is what we have grouped them under hormonal factors and mechanical factors. Hormonal factors and mechanical factors. So let's see the hormonal factors. We have estrogen theory. We have estrogen. So during pregnancy, most of the estrogens are present in a binding form. In fact, when they are pregnant, most of the estrogens are in a binding form. They are in the mother's blood, but they are in the binding forms. But the later part of pregnancy, you see that there will be a lot of estrogen moving freely in the bloodstream of the mother. That is getting to the later part of pregnancy, when the woman is getting to term. That's where you see a lot of estrogens increasing, and then that will then it will then start working on the myometrium of the uterus. That's the muzzle layer of the uterus. It starts displaying on the myometrium of the uterus. And then there are certain things that will also come into action. That is the display of oxytocin receptors, and then gap junction. What happens is that we all know that oxytocin is being released from the posterior pituitary gland, right? But then getting to term, when the pregnancy is getting to an end, then this oxytocin will be releasing into the bloodstream. What is it going to do? Oxytocin, remember, please let me tell you, oxytocin, once it gets to the blood, there are 2 areas that it goes to work. It goes to the myometrium of the uterus. It goes to the breast of the uterus. It's a hormone. Any hormone that gets into the bloodstream. You know, hormones pass through ductless, they are ductless glands. Let's put it that way. The hormones are coming from ductless glands. And so that the oxytocin is being produced from the posterior pituitary gland. It doesn't pass through any duct, but it is poured into the bloodstream directly. It has a target organ that it is going to work on. The target organ is the breast and then the uterus. Please take it. When I'm saying all this, you jot it down for objective sake. So when you meet it anywhere, you can select the right answer. Okay, that is it. So that is the hormonal factor. Now, progesterone is also another hormonal factor. Progesterone withdrawal theory. There's something we call progesterone withdrawal theory. It's a hormone that is designed to promote pregnancy. No 2 ways about it. Progesterone, we know it acts, it helps during pregnancy. What does it do to help pregnancy? It relaxes all plain muscle fibers in the body. Please take note of that. Progesterone. Initially it is produced by the ovaries. But then when the placenta is at the 12th week, it takes over the production of the progesterone and estrogen. So progesterone will be produced. And once it is produced, we are saying that it is withdrawn from the blood towards the end of pregnancy. And so we say progesterone withdrawal theory. Progesterone withdrawal theory. We are saying that progesterone, it helps to promote pregnancy. It maintains the pregnancy. But then its presence inhibits uterine contraction. When progesterone is there, it prevents the uterus from contracting. Other than that, you get pregnant 3 months, progesterone is saying, hey, I'm coming to cause contraction. Then your pregnancy will be aborted. Pregnancy is 6 months, progesterone say, hey, I'm here, contraction uterus, get rid of the fetus. You see, but it maintains the pregnancy. But then it will get to a point that there will be a drop in the progesterone synthesis when the placenta starts aging. When the placenta starts aging, please, we have reached a very sensitive point. Talk to your children to keep quiet. Tell them you are in the lecture hall, so they should keep quiet. Tell your children at the lecture hall. Okay. So, ladies and gentlemen, I'm saying that progesterone withdrawal theory, we know progesterone to be a hormone that is produced by the placenta to maintain the pregnancy. But then as time goes on, as the pregnancy is getting to term, the placenta will be degenerating. And so the production of the progesterone will be minimal. It will be withdrawn. And once it is withdrawn, it initiates labor. It causes the uterus to contract. Hello?
HAJIA, please, can you go over this place for me? You said progesterone is produced by the placenta.
We are dealing with hormonal factor, and I'm going over it for you, don't worry. I'm talking about hormonal factors that initiate labor. I said we have mechanical factors and we have hormonal factors. And so we have what you call progesterone withdrawal theory. And I said that progesterone, we know, is a hormone that helps maintain pregnancy. It is being produced by the placenta during pregnancy to maintain the pregnancy, meaning that the presence of progesterone will prevent the uterus from contracting. But then at the end of pregnancy, at term, then there's a drop. There's a sudden drop in progesterone synthesis because placenta is getting aging or is degenerating. And that will lead to what we call predominance of exacerbatory action of estrogen. There will be predominance, meaning that there will be an action of estrogen. Though estrogen and progesterone are being produced by the placenta, it will get to a point that progesterone will be minimal. Its action will be reduced, causing the uterus to go into contraction. That is all that I'm trying to say. So that is it. That is a hormonal factor that can cause uterus to contract. Now we have oxytocin theory. Where is oxytocin secreted from? I've just said it. I have said it, so somebody should be able to tell me.
From the
Posterior
pituitary gland.
From the posterior.
From the posterior pituitary
gland.
gland.
Very good. Good. From the posterior pituitary gland. Yes, posterior pituitary gland. So secretion of there's an enzyme called oxytocinase. Oxytocinase is an enzyme. It is being secreted by the placenta. So the oxytocinase, that is an enzyme produced by the placenta, is decreased. the oxytocin, that is an enzyme produced by the placenta, is decreased in quantity when the woman is getting to term. Why? Because the placenta ischemia at term, the placenta is becoming ischemic. So the placenta ischemia will lead to the predominance of oxytocin action. Remember, we are talking about oxytocinase, which is an enzyme that helps to maintain the pregnancy. But getting to term, the oxytocinase will be decreased. The enzyme oxytocinase will be decreased in quantity, right? And then when it happens like that, we are saying that it is happening because the placenta ischemia takes place. It's like blood supply to the placenta site is reduced. It's reduced. That is why, it also reminds me, that is why as a midwife, you should be afraid of post-maturity than preterm. You should be more concerned about the post-matured woman, the woman whose pregnancy is overdue. Be worried for her. Be concerned. Find a way of getting the baby out. Else, because of this physiology that we are talking about, she's likely to lose the baby. She will deliver the baby all right. Not even all right, because molding cannot even take place well in the post-mature baby. And so the post-mature baby is more likely to die than the preterm baby. After the preterm baby, once you apply the warmth, you express breast milk and give to the baby through NG tube, through that, baby can easily survive. But what about the post-term baby? That oxytocinase is vanished in the blood. Oxytocin has come into the bloodstream to initiate contraction, but because of post-maturity, there's no overlapping of the skull bones. So look at all these things that we are talking about. Therefore, when we talk about oxytocin theory, this is one of the most important biochemical factors in stimulating uterine contraction. It will cause the uterus to contract and expel the baby out. That is the oxytocin theory. Please, is it clear? Please, are we okay? Can I continue?
Yes,
sister. Okay,
Yes,
that's
sister.
good.
Hello.
Then we are talking about fetal cortisol theory.
Hello.
Fetal cortisol, yes.
Please, HAJIA.
Fetal cortisol. Yes, please. Go ahead.
Please, initially, I heard that you said the progesterone is produced by the ovaries, but later I heard you said the placenta.
Oh, progesterone, maybe when we study anatomy, when we get to the menstrual cycle, then you appreciate that.
12 weeks of pregnancy, the placenta takes up.
Thank you very much. That's what I said. Thank you. Who bailed me? Who said it?
Aisha and
Aisha,
Kansa.
Aisha and Kansa, yeah. Hey, Aisha, I know you. I see. Okay. So I said it. I said that initially, progesterone is produced by the ovaries. But when the placenta is at the 12th week of gestation, it takes over from the ovaries and it starts producing the progesterone. I hope it's clear, the one who asked the question. Is it clear?
Yes, sister. Yes, please.
Oh,
yes, please.
You do understand.
Yes, please.
Okay.
Yes.
So the next hormonal
Hello,
factor, yes, sister.
Please, I beg you,
Yes,
please, can you
ahead.
go about with the the estrogen for me? I beg you.
Oh, we are going back there from the beginning. Oh, we said estrogen theory. That during pregnancy, most of the estrogens are present in the binding form during pregnancy. But then towards the later part of pregnancy, we said there will be more freely estrogens that will appear, increasing the contraction. And the contraction will start from the myometrium. I said it to you. And then I also mentioned prostaglandin synthesis in association with the estrogen, so that it will digest the collagen fibers in the cervix to soften the cervix and initiate labor. But we are more interested in the oxytocin theory. Okay.
Okay. Thank you.
You're welcome, sister. Okay, let me continue. So I was talking about the fetal cortisol theory. Fetal cortisol theory. So it increases, there's increase in the cortisol production from the fetal adrenal glands before labor, inhibits progesterone production from the placenta. What we are trying to say is that as the mother's tissues or organs are trying to produce the estrogen, the oxytocin to initiate labor, the fetus also say, hey, I'm the one that is fighting my way out to come out of the uterus. What can I also do? I'm just giving a scenario. So the fetus, what can I also do to help myself? I want to go out of this uterus and go to the world. My mother has produced oxytocin. My mother has produced progesterone withdrawal syndrome. There's contraction of the uterus. What am I doing to help myself as the fetus? So the fetus also take measures. So the fetus will also start producing what we call cortisol. Cortisol is produced from the fetal adrenal glands. Where can we locate the adrenal glands? Ladies and gentlemen, I'm asking you. I'm Prechum Rosemary. Where can we locate the adrenal glands? I'm Prechum, say it. You know it, say it. Rosemary and Prechum, I'm waiting for you. Okay, anybody? Okay, it's being produced from the adrenal glands. The adrenal glands are situated on top of the kidneys. You have forgotten it. So the fetal adrenal glands that are situated on top of the kidneys will also produce a hormone known as cortisol that will also help with the initiation of labor. I hope it's clear now.
Yes, sister. Yes, please. Yes, sister, okay. Please, can you go over the definition for fetal cortisol theory?
Oh, okay. I said that the fetal cortisol theory, I said increased cortisol production from the fetal adrenal glands before labor. It inhibits progesterone production from the placenta. We all agreed that progesterone is being produced by the placenta, as somebody asked and I explained. You see, so that what the fetal cortisol theory does is that the cortisol produced by the fetal adrenal glands, once it is increased, it prevents the production of progesterone. And if progesterone is no more, the uterine contraction will start. So the fetus wants to help itself. That's why it is checking those who are, causing the pregnancy to maintain. It's like, I want to go out of this place. And you progesterone, you are maintaining the pregnancy, isn't it? Somebody will say, if you know the way I'm suffering over here, your progesterone, you should have stopped maintaining the pregnancy and let him come out, so I'm coming to work on you. So the cortisol will then attack. It will work on progesterone. That progesterone stop production. I don't want any trouble. I want to go out of the uterus. So once progesterone is inhibited by cortisol that the fetus adrenal glands has produced, then it will initiate contraction. After all, it was the progesterone that was preventing the uterus from contracting.
Yes.
Right.
Yes.
So I think it's clear now. I think it's clear.
Yes, please.
So HAJIA,
Yes,
it means
please.
both the
Yes, please.
oxytocin and the
Yes,
cortisol will
please.
help with the contractions.
Yes.
Okay.
Yes. So cortisol say no way. I won't let you maintain any contraction. Progesterone. I won't let you maintain the pregnancy. I want the uterus to contract. So stop your progesterone